Imagine a single idea, an idea so revolutionary, so profoundly ahead of its time, that its brilliant champion faced ridicule, isolation, and, well, professional ruin just for daring to challenge the status quo he was born into. Today, we're taking a deep dive into exactly that kind of story. We're exploring the remarkable life and the enduring, the long, unacknowledged impact of Ernest Amory Codman and his revolutionary end result idea in healthcare.
Right. And at its essence, this isn't just about, what happened to a patient after treatment. It's critically about why it happened, and most importantly, how to prevent similar outcomes or failures, really, in the future. It's all about learning, continuous improvement, but in a systematic way.
So our deep dive today will unpack Codman's fascinating life, this deceptively simple concept he championed, and its surprisingly modern implications. Implications for everything from individual patient care right up to large-scale hospital management. We're drawing heavily on Avedis Donabedian's insightful 1989 article, The End Results of Healthcare, Ernest Codman's Contribution to Quality Assessment and Beyond. Okay, so let's start with the man himself, Ernest Amory Codman, born during Christmastide 1869 in Boston. He called himself the thoroughly Bostonian, of pure English Puritan stock on both sides. You get the picture.
Oh, yeah. Definitely part of the establishment. He had all the educational advantages of his caste, as the source puts it. Private school, St. Mark's boarding school, then Harvard College, Harvard Medical School.
And an internship at Massachusetts General Hospital, MGH.
Exactly. He was, as he said, fashioned for success as the world reckons success.
And he was on that track, wasn't he? Appointed assistant surgeon at Mass General.
He was, though he himself said it was through family position, acquaintances, well-wishers. A bit dismissive, maybe.
Sounds like it. A clear path to conventional success back then.
But then this path was, well, interrupted by what he came to call his one inveterate flaw.
Which was?
The end result idea.
That's quite a way to describe what seems like a brilliant insight. A flaw.
Right. He said this dominant idea came to him around the turn of the century and just sort of grew, took hold in his mind.
And there was a specific moment, a turning point.
Apparently so. The source calls it his Damascus moment. That sudden, profound realization. It happened in the summer of 1910. He was in a hansom cab, like a horse-drawn taxi, returning to London with another surgeon, Edward Martin. They'd just visited a tuberculosis sanatorium out at Frimley.
And Martin's reaction.
Well, this is fascinating. Martin, who was also a very driven man, immediately seized upon this end result idea. For Martin, it was the missing piece, the catalyst to crystallize his own obsession.
Which was?
Forming an American College of Surgeons.
Okay. So they saw the connection.
Instantly. Both men realized that measuring these end results, as Codman called them, would be the tool, the way to verify claims of surgical skill. And crucially, to standardize surgery across different hospitals, it just clicked for both of them.
And for Codman, this idea became, well, everything. His monomania, as he called it.
Obsession is right. It consumed him. So much so he actually consulted distinguished alienists, psychiatrists today about his own sanity.
Seriously, what did they say?
It's quite profound, actually. They told him that only the soundness of the obsessing idea distinguishes the healthy from the sick.
Wow. So if the idea is good...
And the obsession isn't madness, it's, well, vision. Even later in life, he called it the great and still unsuccessful interest of my life.
Unsuccessful.
Yeah.
It tells you a lot about the struggle.
It really does. The resistance he faced.
So let's unpack this idea. What was this simple yet profound concept?
In his own words, Codman said it's merely the common sense notion that every hospital should follow every patient it treats, long enough to determine whether or not the treatment has been successful.
Okay, makes sense.
And then, and this is the crucial part, to inquire, if not, why not, with a view to preventing a similar failure in the future.
If not, why not? Simple, powerful.
It's that cycle. Care, assess the result, learn, improve.
And he didn't just have the idea, he figured out how to do it. The end result system.
Exactly. Very practical, almost industrial, you could say.
How did it work?
Each patient got an end result card, simple card, and on it, in the briefest possible terms, you'd record symptoms, the diagnosis, the treatment plan, any problems in the hospital.
Complications, things like that.
Right. Complications, discharge, diagnosis, and then the key bit, the result each year afterward.
Each year. That's long-term thinking.
Very. It allowed assessment of both the initial diagnosis, was it even right, and the true long-term results of the treatment.
Even if you can follow up for years, you could still look at what happened in the hospital. Deaths, major issues.
Exactly. Even just reviewing in-hospital events or deaths was a start. better than nothing, which is often the standard.
And who looked at these cards? Who did the reviewing?
He proposed an efficiency committee in each hospital.
Efficiency committee. Sounds modern.
It does. And it was meant to be multi-stakeholder. You'd have trustees, administrators, and medical staff all involved.
So not just doctors reviewing doctors.
No, that was key. Their job was to review the unsatisfactory results, figure out the reasons for failing to attain perfection, and then take action.
What's really interesting there is it wasn't just about outcomes like we talk about today.
No, Donabedian points out it was a concurrent assessment of the care itself and its immediate consequences, which then triggered a review of the whole process.
Decades ahead of his time, anticipating later quality assessment work.
Truly.
And he was specific about why things might go wrong, the reasons for failing to attain perfection.
Oh, very specific. He laid out a whole framework.
Like what?
Well, obvious things like lack of technical knowledge or skill, or lack of surgical judgment, lack of diagnostic skill, purely medical factors,
Right.
but also systemic issues, lack of care or equipment, and patient factors, personal or social conditions preventing cooperation, or simply the patient's unconquerable disease.
Right. Things beyond the doctor's control sometimes.
Exactly. And finally, just the inherent risks, the calamities of surgery, or the accidents and complications over which we have no known control. He tried to cover everything.
It's incredibly thorough, like a diagnostic checklist for failure itself.
You could see it that way. And he even created a system to classify cases.
How did that work?
It was like a grid, a matrix. 29 anatomic divisions like body parts and 9 pathologic divisions, disease types.
Creating hundreds of little boxes.
261 cells, yes. It allowed someone to quickly find similar cases to study and compare.
Even without modern statistics.
Right. He didn't have case mix standardization, adjusting for how sick patients are. His focus was still clinical. Did the care make sense for this patient? Was the outcome good for this type of case? Very hands-on.
This deep conviction, this monomania, it clearly fueled some incredibly bold actions, provocative actions.
Oh, absolutely. He wasn't shy.
Like resigning from Massachusetts General after 15 years.
Yes, in 1914. Loyal service, then boom, resignation.
But the kicker is, he reapplied the very same day.
The same day, as surgeon-in-chief.
And his justification.
Basically, my results are better. He said, the results of my treatment of patients at their hospital during the last 10 years had been better than those of other surgeons.
Wow. Talk about throwing down the gauntlet.
The source calls it a calculatingly dramatic, even provocative act. It was meant to force the trustees to notice his protest against the seniority system. Promotions based on time served, not results.
I bet that didn't make him popular.
Understatement of the century. And he topped it the very next year, 1915.
What happened then?
He was chairing a meeting of the Suffolk County Medical Society. Big deal. And he unveiled with a great flourish a cartoon.
It's a cartoon at a medical society meeting.
Yep, picture this. Boston's elite Back Bay residence depicted as an ostrich, head buried deep in the sand. And it's kicking back golden eggs of remunerative surgical interventions towards the Harvard doctors.
Golden eggs. So unnecessary, profitable surgeries.
That was the implication. While the hospital trustees and the university president stand around debating whether to reveal the truth about these questionable operations.
Oh my goodness, how did that go over?
Predictably, the audience was first aghast, then apparently in an uproar.
People walked out.
Some walked out in anger, yeah. But apparently a great majority were just amused, which might be even more insulting in a way.
But the consequences for Codman were serious.
Very serious. Disgrace, loss of friends. He had to resign his chairmanship. He was separated from Harvard. His income dropped noticeably.
We really burned his bridges for this idea.
Completely. A true maverick. He paid a heavy price.
So what did he do then? Where did he go?
His fallback was his own small private hospital, sometimes described as 10 beds, sometimes 12. Tiny.
Not exactly the marble halls of Mass General.
No, it was a modified apartment house in a rather crowded part of the city. He admitted it wasn't fancy. Dust in our corners of the sterilizer cost 87 cents. Secondhand X-ray machines.
But this was his lab, right? To prove his system worked.
Exactly. To show the feasibility and superiority of the end result system on his own terms.
An outlaw institution, as the source says. Was it financially viable?
Not really. He said it cost him money. He'd have been better off paying to operate somewhere else than running his own place.
But he kept going.
He did. Then World War I intervened.
What did he do during the war?
He served as a major in the Canadian Army, interestingly. organized an emergency hospital in Halifax after that massive explosion there,
The Halifax explosion, yeah.
and apparently left it running smoothly with an end result card for every patient.
Even in total chaos, he implements the system.
He couldn't help himself. Later, he did similar work in the U.S. Army Medical Corps.
What happened after the war?
He came back to find his hospital closed. He was in debt with no borrowing capacity and somewhat disillusioned.
Understandable.
As to the possibility of altering the ways of human nature by my intellectual efforts, you can really feel the bitterness there.
But the passion didn't die completely.
No, it reignited eventually. He got involved with the Registry of Bone Sarcoma, which was important work, and then spent 4 years writing his major treatise, The Shoulder, privately published in 1934.
And in that book.
He calls the end result idea his chief achievement and his legacy to the world. Still fighting for it.
So as this idea matured, Codman's thinking got even more radical, didn't it?
It really did. He started to see the end result not just as a measure, but as the only true product of healthcare.
The only true product, what does that mean?
Well, he acknowledged hospitals produce knowledge, they educate doctors and nurses.
Sure. Research, teaching.
Right. But when it comes to the actual care given to a patient, the output, the product, is the satisfied and relieved patient. Or, put another way, the improvement in health attributable to care.
That's a fundamental shift in perspective.
Huge. And his goal was to demystify healthcare, to get rid of the humbug, as he put it.
He even compared medical care to an ordinary commercial article. That sounds pretty blunt, almost cold.
It does sound provocative, doesn't it? But his point wasn't to dehumanize it. He argued that much of medical care, like a commercial product, could have its quality standardized. It could be produced efficiently, especially through specialization.
So he wasn't saying all care is like that.
No, but for common procedures, predictable conditions, why not aim for reliable, standardized quality?
And the end result idea was the key to achieving that.
Yes. He saw it as the vital link connecting the science of medicine with the science of management. He called it the introduction of the comparative principle into clinical science and the use of the principles of scientific management in hospital organization, bringing business-like rigor.
And his idea of efficiency wasn't just about saving money, which is often how we hear that word today.
Well, not at all. His primary focus was therapeutic efficiency, meaning the best possible application of recorded knowledge to each case. Using what we know works effectively.
So avoiding waste.
Exactly. Avoiding useless visits, hospital stays that drag on too long, and especially avoidable errors. He pointed out that the cumulative cost of those errors is greater than the cost of good medical care. Investing in quality pays off.
That's a very modern argument, too.
Absolutely. His overall concept of efficiency was incredibly broad. Donabedian says it covered what we now call effectiveness. Does it work? Clinical efficiency is the medical process smooth. Production efficiency are resources used wisely, and efficiency of allocation are the right resources going to the right patients.
It was almost a moral thing for him, wasn't it?
It really seems like it. He said, efficiency must acknowledge truth and use it in a truthful way. It is the scientific use of science.
Using science scientifically.
Right. He believed his system would make medical work more scientific and our practice more efficient and honorable, moving medicine away from guesswork, from humbug and art, toward science and industry.
So let's talk about the uses he envisioned. It wasn't just one thing. The applications were incredibly diverse and still feel relevant.
They really do.
First, obviously, monitoring quality. In a time when practice was based on, tradition and anecdote, his system was a radical call for systematic measurement.
Absolutely. Moving from guesswork to data, he saw how the hospital environment, the incentives, shaped what doctors did. He wanted accountability.
And second, he saw it as crucial for advancing clinical science.
Yes, for individual doctors, it was a tool for continuing education. Really looking at your own results, successes, and failures to learn. He had this startling view of surgery back then as often just a series of unplanned experiments. Whose results were unstudied, unrecorded, and undisclosed. His system would change that, turn practice into systematic learning.
He even sketched out a plan for technology assessment and diffusion, didn't he? Managed by the American College of Surgeons.
A really sophisticated idea for the time. Track innovations from doctors, test the promising ones thoroughly in hospitals.
Then test them in other hospitals.
Right. Compare results, discuss them at meetings, publish descriptions in the college journal, naming the experts, and finally get official AMA endorsement.
That's a whole framework for validating new treatments.
Exactly. Verifying value, speeding up adoption of good ideas, creating a directory of who's good at what, linking quality monitoring directly to research, and spreading best practices.
Then there's establishing accountability. Where did he think that started?
Within the hospital itself, collaboration was key. Medical staff, administrators, and crucially, the trustees. He said none could do it alone.
And the trustees, the lay people on the board, had a specific role.
A critical one? He said it was their responsibility to insist that the end result system should be used. They had to demand it.
That must have really shaken things up, challenging the doctor's traditional autonomy.
Oh, definitely. But Codman saw it as necessary for the interests of the whole. He viewed the hospital as this community, where the patient, the student, the profession, the chief, the trustee, the community, even global medical science, they all own part of the case. Shared stake, shared responsibility.
A very modern systems thinking view.
Totally.
And he didn't stop at the hospital walls. He wanted accountability to the public.
Yes. He figured it would deeply surprise everyone to learn that results weren't routinely studied. Seems obvious now, but wasn't then.
He thought hospitals should basically certify their quality.
Pretty much. Certify the standard of care they can expect to get and provide the evidence. He really does sound like a man of our time in that respect.
Okay, what about inside the hospital? How did he see the end result system affecting operations?
He thought it should drive resource allocation and personnel policies. Since the end result was the product, measuring it tells you about productivity and efficiency.
So promotion shouldn't be based on who you know or how long you've been there.
Absolutely not. He hated appointments by nepotism or seniority. He wanted a merit system of promotion based purely on verified results. That encourages clinical accuracy.
If you get good results, you move up. If not,
Well, maybe you shouldn't be doing that particular thing. Which leads to his next point. Promoting functional differentiation.
meaning specialization.
Yes, assigning certain types of patients to specific wards or doctors who'd proven they were good at treating them.
And differentiation between hospitals, too.
Right. Some hospitals might stick to simpler cases they handle perfectly, while others tackle the really complex stuff. Know your strengths.
And he had that funny example of something he stopped treating himself.
Oh yeah, the classic Codman wit. He resolved not to treat oblique fractures of the clavicle in young ladies who wear low-neck gowns.
Right.
Because he wasn't getting good cosmetic results, and presumably they cared about that. It's humorous, but it shows his own accountability. Know your limits, focus where you excel.
Then there's effectuating informed choice and stimulating fair competition. How do results fit in there?
He saw it benefiting both doctors and patients. For GPs, the arbiters sending patients to specialists, they needed real data, not just the unexpurgated deluge of medical articles.
Help them make better referrals.
Exactly. And for patients, he said bluntly, no one, be he rich or poor, knows whether he really has the services of a good surgeon. He wanted transparency.
Hospitals should publish their results.
Charitable hospitals, yes. And he practiced what he preached. He published his own hospital's reports, all deaths, all cases treated.
I just gave them away or sold them cheap.
Yeah, free or for $1. He asked, why should not the layman see them if he cares to? Radical transparency.
What about advertising? He had a unique take on that, too.
Very unique. He defined it broadly: any public appearance, even titles, and said it was a necessity if the usual professional channels failed to guide patients properly.
And his famous quote about secrecy.
Secrecy is the peculiar disease of efficiency. Publicity is the cure of the disease, secrecy. He saw openness as the antidote to poor quality and inefficiency.
Finally, he even tied results to money, pricing services, and remunerating providers.
Right down to publishing his own fees, like a fixed fee, not over $120 for 2 weeks. The source notes how that prefigures today's per-case payments.
His motto was, $100 hospital with a $100 surgeon, aiming for value.
Exactly. He argued for standard fees for standard care, the commercial article stuff, but higher fees for cases needing real expertise based on the surgeon's proven ability to get better results.
Pay for performance, essentially.
Way ahead of its time. He even proposed no payment be made unless the patient gets well and offered to live by that rule himself.
That's incredibly bold. Did he figure out how to value life for payment?
He struggled with that, understandably. His eventual idea was surgeons get a reasonable fee, but a large sum should go to an endowed institution for research if the outcome was excellent.
So, linking financial success back to the altruistic mission.
Yes. He saw medicine as a business, but wanted to harness that drive for good. He hated how charitable institutions used their prestige but hid their actual results, called them combinations in the restraint of trade.
Wow, strong words.
He even imagined groups of surgeons competing openly based on results, kind of foreshadowing today's market forces in healthcare.
So, looking back at Codman the man,
Hmm.
what does it all mean for us now? He clearly struggled.
Oh, deeply. He talked about suffering from a sense of isolation, feeling like his views were so different it made him suspect myself of being peculiar.
People call him metacentric.
And he admitted being a zealot, driven by that Puritan conscience. He felt unsuccessful and embittered in his own lifetime.
But despite all that personal pain, he knew he was onto something important.
Profoundly. He wanted vindication, especially from MGH and Harvard, the places that formed him, but then largely rejected him.
He was confident history would prove him right.
Absolutely. He predicted the end result idea would become an intellectual landmark that Harvard would eventually claim as a jewel in her crown, alongside anesthesia and social service.
He even put that hope in his infamous cartoon.
Yeah, a detail showing armies of medical students flocking to Harvard because they believe the end result system will be used there. Wishful thinking at the time, perhaps.
It's poignant. You picture him maybe happiest outdoors, like he described, adrift on some out-of-the-way pond, momentarily expecting a strike from a big one. A moment of peace.
A nice image. But the most vivid one is how he ends his book, The Shoulder.
It's a drawing.
Yes, a drawing of himself in a hot air balloon way up high, unfurling this huge banner.
And it reads,
The end result idea. Just that. Floating above it all, proclaiming his life's work to the world. Powerful statement of conviction.
what an image, what a story.
Codman's ideas, born over a century ago, pushed for this radical transparency and accountability in healthcare outcomes, long before we had the computers and tech to really capture it all easily. Which raises, I think, an important question for you listening. What end results are we failing to measure today? In our own jobs, our industries, our fields of interest, what critical outcomes, if revealed, could spark a similar kind of revolution? What sacred cows do we cling to that stop us from embracing maybe simple, truthful principles of efficiency and learning?
That is a powerful thought for own pursuit of understanding. What will you choose to dive into next?